Good morning, ladies and gentlemen. The topic of my today's lecture is primary and secondary Raynaud's phenomena. This lecture is taken primarily from the CME article published in JAAD in January 2024 and from chapter 125 of Textbook of Dermatology by Rook. I am Brigadier Asher Ahmed Mashood. I am Professor of Dermatology and Aesthetic Medicine. You can follow me on my Instagram account and email me or WhatsApp me. Introduction. The Raynaud's phenomenon was first described in 1862 by Maurice Raynaud as a change of extremities in response to cold or stress. So the phenomena derives its name from the first person who draw attention of the world to this phenomenon. It is well understood as a vasospastic condition affecting the acral and digital arteries in response to cold or stress, and identified by characteristic biphasic or triphasic color changes in fingertip, toes, less often nose, earlobe, tongue, lip, and nipples. So this paragraph contains many useful informations. The first is that it is a vasospastic condition, a condition resulting in vasoconstriction of the peripheral blood vessels, and it affects definitely those areas which have the end vessels like toes, fingers, nose tip, earlobes. And it is characterized and it occurs in response to cold and stress, because these two conditions, both the cold and the stress, results in autonomic vasoconstriction of the blood vessels. And there is a typical biphasic or triphasic color changes, which I will explain later. The vasospasm, as the vasospasm resolves, there is suffusion and hyperemia in affected area. As it usually happens after the vasoconstriction resolves, the area becomes hyperemic for some time. This is a typical Raynaud's phenomena. That is the triphasic or triphasic color changes, white due to lack of blood flow because of vasoconstriction, and this is followed by blue discoloration because of lack of oxygenated blood to the peripheral tips. And once the vasoconstriction is relieved, then hyperemia or erythema because of return in the blood flow. Raynaud's phenomena is a relatively common vasospastic condition, and it is largely divided into two distinct subtypes, primary and secondary. The primary Raynaud's phenomena is common and occurs in approximately 5 to 7% of the population, so quite a big number. It is a relatively benign condition and is not associated with any underlying systemic disease. The secondary Raynaud's phenomena occurs most commonly in context of autoimmune and connective tissue diseases. It is associated with progressive biochemical and structural changes in the vasculature and may result in necrosis and loss of digits. So the primary Raynaud's phenomena is not as dangerous as the secondary Raynaud's phenomena, primarily because primary Raynaud's phenomena is not associated with any underlying condition, but the systemic Raynaud's phenomena is always associated with underlying autoimmune and connective tissue diseases. Therefore, it is of utmost importance to recognize and treat the secondary Raynaud's phenomena early to help prevent not only the digital necrosis, but possible association of internal organ damage as well. The epidemiological differences between primary and secondary Raynaud's phenomena. So, as far as the epidemiology and sex predilection is concerned, primary have more female predilection, while secondary does not have any special gender bias. And the time of presentation of primary is less than 30 years and is more than 30 years in secondary. There is vasoconstriction in both. Biochemical and structural abnormalities within the microvascular system is not seen in primary, but seen in secondary. Endovascular remodeling, fibrosis, and stenosis is not seen in primary, but seen in secondary. Exacerbating factors like smoking is positive in both these two conditions. Vinyl chloride is positive in both these two conditions. Use of high intensity vibratory tools is common in both conditions, and frostbite is common in both conditions. The primary Raynaud's phenomena pathogenesis. The primary Raynaud's phenomena is an overactive vasoconstrictive response in digital cutaneous vessels without an endovascular pathology. So this is important to recognize here that this is an overactive vasoconstrictor response to cold and stress rather than any pathological condition. So the causes of this overactive vascular vasoconstrictive response is a vascular abnormality or abnormalities in autonomic nervous system. Both these two factors lead to vasoconstriction, which presents as the dynamic color changes as highlighted before. The vascular abnormalities. Normally, the endothelium produces a number of substances that keep the blood vessels dilated. In Raynaud's phenomena, there is an overactivity of alpha 2 receptors, which are the vasoconstrictor receptors in an artery, expressed in both perfusing and non-perfusing capillaries. There is also a deficiency of vasodilator substances like nitrous oxide, which lead to vasospasm. So there is hyperactivity of vasoconstrictor receptors and deficiency of vasodilating chemicals like nitrous oxide. Abnormalities of autonomic nervous system. In cases of stress, one of the precipitating factor of Raynaud's phenomena, there is release of norepinephrine at the nerve endings that results in spasm or constriction of blood vessels. This is a normal stress phenomena. The diagnostic criteria of primary Raynaud's phenomena. There is history of episodic attack of acral pallor and cyanosis. There is absence of any peripheral vascular disease. No evidence of tissue necrosis. Normal nail fold capillaries. Negative ANA test and normal ESR. Triggers and risk factor of primary Raynaud's phenomena. Smoking can trigger this phenomena. Non-selective beta blockers with both beta-1 and beta-2 adrenergic activity can trigger it. Estrogen use can trigger it. There is a genetic predisposition as well. Cold will trigger it. In female gender will trigger it. And young people, 15 to 40 years, are also predisposed to this primary Raynaud's phenomenon. Associations. Again, the differences between primary and secondary Raynaud's phenomena. Lots of associated conditions are seen with secondary Raynaud's phenomena, but they are not seen in primary Raynaud's phenomena. For example, the vasospastic disorders association, like Prinzmental variant coronary angina and migraine disorders, are commonly associated with primary but not with secondary. Autoimmune connective tissue diseases are not associated with primary, but they are associated with secondary, and the diseases include systemic sclerosis, which is the most important, then SLE, mixed connective tissue disease, and dermatomyositis. Other rheumatological diseases include rheumatoid arthritis, Sjogren's syndrome, and vasculitis. Vasculo-occlusive diseases are also not associated with primary but associated with secondary. They include the atherosclerosis, Burgess disease, and thromboembolic disease. No hematological condition is associated with primary, but cryopyrimidininemia, paraproteinemia, polycythemia, cold agglutinin diseases, protein C and S deficiency are all associated with secondary phenomena. Medications associated with primary, mentioned before, non-selective beta blockers, the migraine therapy, estrogen replacement therapy, and caffeine. While similarly, non-selective beta blockers, the migraine therapies, estrogen replacement, and caffeine also play a role in secondary Raynaud's, but also amphetamine, bleomycin, cisplatin, cyclosporin, interferon alpha, and vinblastine. Infections, no infection is associated with primary, but hepatitis B and C, parvovirus, and mycoplasma is associated with secondary. Then anatomic syndromes like Scalenus anticus syndrome and cervical ribs are associated with secondary. Secondary Raynaud's phenomena. The associations I mentioned before, including the infections, toxins, and occupations. The microvascular pathology in systemic sclerosis complex include the biochemical abnormalities within the endothelial cells and vascular systems and progressive structural remodeling in the arteries. Both of them contribute to secondary Raynaud's phenomenon. These changes generate severe, progressive, and irreversible clinical manifestations that include the digital pitting, ulceration, sclerodactyly, and resorption of the underlying bones resulting in telescopic digits. The systemic manifestations in secondary Raynaud's phenomena. I mentioned before that there are no systemic manifestations in primary Raynaud's phenomenon. So the secondary manifestations are there is overt cutaneous vasomotor activity and subsequent endovascular pathology in secondary Raynaud's phenomena patients. Also occurs simultaneously in vasculature of heart, lungs, and kidney. So in heart, it can result in heart failure and sudden cardiac arrest. Lungs, it causes pulmonary atrial hypertension, pulmonary fibrosis, and interstitial lung disease. Kidney, it leads to renal crisis. Esophagus, it leads to GERD and GAVE, which is gastric antral vascular ectasia. Skin manifestations include digital necrosis and gangrene, sclerodactyly, and skin tightening. The pathogenic factors in secondary Raynaud's phenomena include vasospasm and impaired vasodilatation, dysfunctional angiogenesis, fibrosis and structural dysfunctions, thrombosis, and coagulopathy. So these factors, number 3 and number 4, are not seen in primary. So among the pathogenesis, we are going to discuss the vasospasm first. There is exocytosis of endothelin-1, which is a potent endogenous vasoconstrictor, which is neither produced nor secreted by healthy endothelium. This, once secreted, promotes thickening and potent vasoconstriction of the vessel wall. The endothelin levels are reliable clinical marker of disease severity and act as predictor for digital ulcer development in systemic sclerosis. Impaired vasodilatation. In systemic sclerosis and secondary Raynaud's phenomena, there is decrease in both endothelial nitrous oxide and inducible nitrous oxide. Nitrous oxide is one of the potent vasodilator. The failure of nitrous oxide pathway and decreased expression and increased expression of vasoconstrictor like dimethyl arginine, which is a competitive inhibitor of nitrous oxide, all contributes to the vasoconstriction and decreased vasodilatation. Along with increased endothelin-1, This is the asymmetric dimethylarginine is shown to be a strong predictor of digital ulcers in secondary Raynaud phenomena. So both endothelin 1 and dimethylarginine are the predictor or development of digital ulcers. Increased inducible nitrous oxide activity lead to fibrosis in patient of systemic sclerosis. Then the second phenomena is dysfunctional angiogenesis. Normally, a persistent hypoxia and tissue ischemia promote development of new blood vessels and new vascular networks. This function is profoundly distorted in systemic sclerosis and in secondary Raynaud's phenomenon. There is significant elevation of both pro-angiogenic factors and anti-angiogenic factors in these conditions. Systemic sclerosis causes progressive destruction of microvasculature, reduction in density of capillaries, which is evidenced by digital ischemia and nail fold capillary dropouts. Additionally, the dysfunctional angiogenesis in systemic sclerosis is demonstrable through abnormal corkscrew capillaries and telangiectasias, mainly at the nail fold. In systemic sclerosis, vascular endothelial growth factors may also be induced via non-hypoxia-dependent mechanisms. However, this is not sufficient to promote the effective angiogenesis. Rather than this persistent elevation leads to formation of disorganized vascular network. So everything regarding the new vascular development is disturbed in these conditions. The third factor is fibrosis and structural dysfunction. An early vascular pathologic event in systemic sclerosis is the invasion of mesenchymal myofibroblast cells into the vascular wall mediated by increased tumor growth factor beta, endothelin, and angiotensin II produced by pathologic endothelial cells. This results in fibrotic thickening of vessel wall, intimal hyperplasia, and gradual narrowing of arteriolar lumen and ultimately vessel dropouts. This progressive fibrosis of tunica adventitia can exert extrinsic compression on vascular lumen, which also limit the vasodilatation response. The fourth and last factor is thrombosis and coagulopathy. Secondary Raynaud's phenomena is often accompanied by microvascular thrombosis of capillaries and small vascular structures. Multiple contributors to this include increased exocytosis of ultra-large von Willebrand factor by the vascular endothelium and elevated thromboxane level, which both promotes platelet aggregation. Since endothelial nitrous oxide-driven nitrous oxide production inhibits platelet aggregation, and as nitrous oxide production is reduced in these conditions, this remains unchecked in secondary Raynaud's phenomena. Now, this slide shows the differences in clinical presentation between the primary and secondary Raynaud's phenomena. First is pain with attacks. The pain is infrequent in primary and frequent in secondary, and is quite severe. Digital involvement. It is symmetric in primary and asymmetric in secondary. May involve thumb? No, it does not involve thumb in primary, but it involves thumb in secondary. Digital appearance after the attack. It is normal in primary and persistent pallor in secondary. Symptoms between the attack. There is no symptom in primary, but there is persistent pain, paresthesias, and numbness in secondary Raynaud's phenomenon. Then digital skin changes are absent in primary, while there are digital ulcers, digital tuft pitting, tissue necrosis and gangrene, and potent autoamputation all are seen in secondary Raynaud's phenomenon. So you can see these different images of Raynaud's phenomena, and all those conditions in which there is persistent necrosis, these are the secondary Raynaud's phenomena. While primary Raynaud's phenomena attacks are often uncomfortable and can impede the quality of life, there is no evidence of tissue damage, and there is characteristic biphasic or triphasic pattern accompanied by numbness or mild pain. On contrary, secondary Raynaud's phenomena show unphasic blanching of digits. This reflects persistent hypoperfusion and inability of digital arteries to mount a meaningful reperfusion response, which is necessary to produce hyperemia. Both disease forms have significant negative impact on patients' quality of life. Now the investigations. The first investigation, which is the most important, is the capillaroscopy. It can be done by a separate instrument or by a dermoscope. In primary Raynaud's phenomena, there is normal capillary density without dilated loops or dropouts or microhemorrhages. But in secondary Raynaud's phenomena, there are giant capillaries, microhemorrhages, with relatively preserved density of capillaries, but later changes, there is reduction in capillary density and progressive vascular dropouts. These are the microhemorrhages, these are the giant capillaries, these are the normal capillaries. So these are the dropout of capillaries here, where you expect capillaries, there are no capillaries. So these are called as the dropout areas. Serological testing. Since primary Raynaud's phenomena is not associated with any systemic or autoimmune condition, so all these serological testing is important for the secondary Raynaud's phenomena. So anti-SCL70, anti-polymerase 3, anti-centromere, and anti-THTO antibody are, if present, they point towards systemic sclerosis. Then serum myoglobulin, CPK, aldolase, MDA5, TIF1G associated with dermatomyositis. Then double standard DNA antibodies, anti-Smith, complement C34, anti-Rho, anti-La, ENA are associated with SLE. E-proteinase 3 antibodies and anti-myeloperoxidase antibody are ANCA-associated vasculitis association. Rheumatoid factor with rheumatoid arthritis, and anti-U1 RNP antibody with mixed connective tissue disease. Then the studies on blood perfusion. Digital perfusion testing. This is done by photophletismography, which is digital blood flow measurement, or laser Doppler imaging and thermography. While uncommon, the secondary Raynaud's phenomena may involve the proximal vascular structures, including ulnar, pulmonary, coronary, and renal arteries that warrant surgical or percutaneous interventions. Now coming to the treatment of these two conditions, first of all, assessing the efficacy of treatment. Treatment response may be measured by patients' reported clinical severity marker or objective measurements of digital blood flow. The clinical severity markers include frequency, severity, duration, and quality of life metrics, or Raynaud's condition score, which allow patient to use a diary of daily self-assessment on an ordinal scale accounting for all these factors. That is frequency of attack, the severity of attack, the duration of attack, and the quality of life. Objective blood flow metrics include assessing the severity of attack based on changes in perfusion that include the infrared thermography, photophletismography, laser Doppler imaging, and laser Doppler flowmetry. First, the lifestyle intervention. These are critical in initial management of Raynaud's phenomena. This is particularly important in primary Raynaud's phenomenon and is often adequately controlled through this lifestyle intervention alone. Patients should be counseled extensively on avoiding cold exposure and other triggers of the attack, which also include the stress factors. Then appropriate full body covering with special attention to hands and feet should be done in cold temperatures and during winter months. If possible, forehead should be covered as well, as cold air across the forehead produces the vasomotor or driver's reflex that induce peripheral vasoconstriction. So just remember that even if you are wearing warm gloves and socks and you are uncovering your head, then even this uncovered head can induce a peripheral vasospasm. When feasible, medications associated with Raynaud's phenomena exacerbation should be avoided or discontinued, like beta blockers, and then similar variety of other medications like caffeine has been implicated. So it is better to stop coffee and all the caffeinated drinks intake. Smoking tobacco is strongly associated with Raynaud's phenomena, and smokers have a high incidence of digital ulcers and gangrene. All patients should be extensively counseled for importance of smoking cessation. A variety of maneuvers may be used to help patients abort the acute attack of Raynaud's phenomena. These techniques are often more effective in patients with primary Raynaud's phenomena because no structural changes are present. The Frisbee maneuver is performed in patients with musculoskeletal limitations, whereby arm extended laterally with simultaneous snapping movement of wrist in rapid succession, as tossing a Frisbee should be done in patient without any musculoskeletal defects or problem. Alternatively, a windmill or swing arm maneuver, like delivering a ball in cricket, may be performed by rotating the arm rapidly in a softball pitching motion. Now, the pharmacological interventions. In the past decade, a variety of pharmacological agents have been developed in the treatment of Raynaud's phenomena. These include specific targeted therapies for patients with secondary Raynaud's phenomena and systemic sclerosis who suffer additional morbidity due to digital ulcers and tissue necrosis. Given its non-progressive nature, primary Raynaud's phenomena should initially be managed with conservative lifestyle and interventions as detailed previously. The refractory primary Raynaud's phenomena pharmacotherapy is indicated and should be limited to calcium channel blockers and topical nitrates only. While in secondary Raynaud's phenomena, aggressive approach with early pharmacotherapy should be adopted to prevent irreversible tissue damages. For those with digital ulcers or tissue necrosis, there should be a concurrent use of more proactive treatment like interdigital botulinum toxin. So first and foremost are the calcium channel blockers. These are most extensively studied medication in both primary and secondary Raynaud's phenomena and generally considered to be preferred first-line systemic agent. Calcium channel blockers broadly fall in two categories based on affinity for cardiac muscles and vascular smooth muscles. The dihydropyridine, which is amlodipine and nifedipine, are less cardioselective, exert greater peripheral effect on vascular smooth muscles, and are preferred over the non-dihydropyridine calcium channel blockers like verapamil and diltiazem. While generally well tolerated, both type of calcium channel blockers have potential to cause lower extremity edema. So among the calcium channel blockers, the preferred calcium channel blockers are amlodipine and nifedipine. Topical nitrates are second-line agents to prevent for the patients who fail with calcium channel blocker monotherapy. Following application, topical nitrates are metabolites to nitrous oxide, thereby producing potent exogenous vasodilatation. exogenous nitrous oxide functions by decreasing tone and increased blood flow. In higher concentration, topical nitroglycerin is absorbed systemically and may cause side effects that include headaches. To avoid this, 2% topical nitroglycerin is mixed with hydrophilic ointment to obtain a 1% mixture. Additional application may be restricted to severely involved digital areas. Caution should be used in initiating treatment with topical nitrates in those patients who are already taking phosphodiesterase inhibitors because it brings to more vasodilatation. Now, phosphodiesterase 5 inhibitor. This should be pursued as systemic therapy in patients refractory to calcium channel blockers. These phosphodiesterase 5 potentiating the effects of endogenous and exogenous nitrous oxide and nitrites. Sildenafil and vardenafil have short half-lives, 3 to 5 hours, and should be dosed up to 3 times daily, while sildenafil have long half-life, that is 18 hours, allowing it for more convenient daily or less frequent dosing. Multiple small observational studies suggested benefit with regard to healing of digital ulcers as well. Importantly, caution should be used while co-administrating phosphodiesterase inhibitors and topical nitrates. When combined, the synergistic vasodilatory response result in profound hypotension. In such cases, 1% nitroglycerin is applied sparingly to severely affecting digits and monitor blood pressure regularly. Then the fourth line treatment is the endothelin receptors antagonists. Endothelin are pathologically elevated in systemic sclerosis and is implicated in underlying disease processes including pulmonary hypertension and severe Raynaud's phenomena phenotypes. Endothelin receptors antagonists thereby limit this endothelin-mediated vasoconstriction. Bosentan, an endothelin 1 and 2 receptor antagonist, was found to decrease formation of digital ulcers, most prominent in those with existing ulcers. Selective endothelin 1 receptor antagonists have also been studied. Embresentan is endothelin A antagonist and is also associated with reduction in digital ulcers. Then botulinum toxin. It's important local therapy for patients with secondary Raynaud's phenomena who are refractory to the initial intervention and those with severe phenotypes, including refractory pain, digital ulcers, and gangrene. And this should be tried before considering surgical sympathectomy. The therapeutic mechanism of botulinum toxin in Raynaud's phenomena is through the blockade of sympathetic adrenergic nerves, thus inhibiting the vascular smooth muscle contraction, and hence resulting in distal blood flow, increase in distal blood flow, and limit the vasospastic response. So basically, this is the blocker of sympathetic adrenergic nerves, which are carrying the vasoconstrictor response to the peripheral arteries. Botulinum toxin also inhibits the endothelial exocytosis of endothelin 1 and von Willebrand factor and blockade of substance P release, thus stopping the vasospasm. It is associated with rapid pain relief and healing of chronic ulcers within 60 days after injection. The most commonly botulinum toxin is injected in the middle of the web spaces where the bifurcation of superficial digital arteries occur. Botulinum toxin may also be injected along the palmar neurovascular bundles of metacarpophalangeal joint. However, the latter technique is less favored with increased risk of hand weakness because it will also paralyze the muscles. The injected units range from 60 to 100 units per hand, and it is recommended to inject slowly 10 units of botulinum toxin into each Webb space. This is a safe injection. 10 units. L-arginine is a semi-essential amino acid and precursors to nitroxide. Abnormal metabolism of nitrous oxide contribute to both fibrosis and vasospasm. Then high level of endogenous methyl arginine may be counteracted by therapeutically increase in circulating L-arginine. It should be started as 1 to 2 gram daily, titrating to 8 to 9 gram daily. Then prostanoids. Intravenous prostanoids considered in patients with digital necrosis refractory to oral medications as an addition or alternative to intralesional botulinum toxin. Systemic sclerosis related secondary Raynaud's phenomena showed the efficacy of intravenous iloprost in improving the frequency and severity of attacks, as well as digital ulcer healing and prevention of new digital ulcer formation. However, these treatments typically require hospitalization or regular visits to an infusion center. Alternative agents and treatments of a specific population. Anticoagulants, antiplatelet agents are particularly useful in patients with secondary Raynaud's phenomena with underlying coagulopathy. This most commonly occur with context of SLE, in which patients have underlying antiphospholipid antibodies. Small studies have suggested that routine anticoagulation with low molecular weight heparin or low-dose warfarin may be beneficial. There are few studies formally evaluating cyclooxygenase 1 inhibitor aspirin in Raynaud's phenomena. However, this is often used given its favorable side effect profile. Interestingly, clopidogrel, which is P2Y12 inhibitor and most potent antiplatelet agent, is recently shown to worsen the endovascular pathology and digital ulcerations. So it is not recommended to use the antiplatelet agents except aspirin. Pentoxifylline with vasoactive properties has been successfully used in treatment of non-operative ischemic claudication. It is reported to aid in treatment of systemic sclerosis-related secondary Raynaud's phenomena, although more research is needed to confirm its effectiveness. Angiotensin-converting enzyme inhibitor and angiotensin II receptor blockers. There are two large RCTs involving angiotensin-converting enzyme inhibitor captopril and quinapril, which failed to show benefit in digital ulcers formation or Raynaud's phenomena severity. Other randomized controlled trial comparing losartan and angiotensin II receptor blocker with nifedipine show reduced in severity and frequency of Raynaud's phenomena attack, with the most significant improvement seen with losartan. Therefore, angiotensin II receptor blockers are preferred over angiotensin-converting enzyme inhibitor as potential adjuvant agent. So losartan is preferred over captopril. Then statins. The pleiotropic effects of statin may improve in endothelial dysfunction in systemic sclerosis, probably by increasing the vasodilatation capacity of systemic sclerosis blood vessels and decreasing the level of pro-inflammatory cytokines. Statins may be considered as useful adjuvants in selective patients with secondary Raynaud's phenomena, including those with low BP. Alpha blocker, prazosin, is an alpha receptor antagonist with vasodilatory effect and studied in treatment of Raynaud's phenomena, although it's not routinely used, but may be an alternate or an adjuvant if other treatment options fail. Serotonin 5-HT inhibitors. 5-hydroxytryptophan signaling is mediated by a family of 5-HT receptor and play an active role in vascular endothelium both as vasoconstrictor peptide and promoting platelet activation. Its precise role in Raynaud's phenomena is not clear, while selective serotonin receptor inhibitors, which are commonly prescribed as antidepressant and anti-anxiolytic, are explored as a treatment option in patients with Raynaud's phenomena, particularly those with already low blood pressure. Interestingly, their vasodilatory effect may induce erythromelalgia in patients with Raynaud's phenomenon. Tissue plasminogen activators. Several case reports have suggested the use of thrombolytics in acute digital ischemia with impending necrosis. They should only be considered in low bleed risk individuals with evidence of acute ischemia who do not respond to vasodilators such as intravenous iloprost or interdigital botulinum toxin. RHO kinase inhibitor. While efficacious for other vasospastic condition, RHO kinase inhibitor, which is fusidil, have not been shown to be benefit in Raynaud's phenomenon. Antioxidant and acetylcysteine shown to be of benefit in 2 studies. Sympatholytics. Rezapine and gonethidine both block sympathetic tone and studied in treatment of Raynaud's phenomena. They are less effective than other treatment modalities. Surgical interventions. Multiple surgical approaches are explored in the treatment of secondary Raynaud's phenomena, particularly in patients with refractory diseases and those with impending digital necrosis. Currently, the endoscopic approaches minimize the morbidity of thoracic sympathectomy. Conclusion. The primary Raynaud's phenomena is relatively common and occurring alone, while secondary Raynaud's phenomena is associated with rheumatological and non-rheumatological diseases. Diagnosis of Raynaud's phenomena is based on characteristic clinical history and physical findings. So the biphasic or triphasic color changes is seen in primary, not seen in secondary, while all the other secondary changes in the digit are seen in secondary Raynaud's phenomena. The secondary Raynaud's phenomena particularly lead to permanent and potential devastating tissue destruction. Therefore, it is important to distinguish between primary and secondary Raynaud's phenomena as early as possible and investigate the potential underlying causes and disease manifestations. As far as the management is concerned, the primary Raynaud's phenomena is managed by lifestyle modifications. Some patients with primary Raynaud's phenomena and most with secondary Raynaud's phenomena require pharmacological interventions, and which include calcium channel blockers, the topical nitrates, phosphodiesterase 5 inhibitors, or endothelin antagonists. Yeah. Additional approaches to those with signs of critical ischemia or those who fail pharmacological therapy include botulinum toxin and digital sympathectomy. So this brings to end of my lecture. I thank you very much for your attention and hope to see you next time with another edition of my talks. Thank you and have a good day.